Hello, today is Wednesday, November 4th, 2020. This is the Standing Committee on Health and Social Development. Would like to welcome the members of the committee here with us today. We have Tricia Altes, Corey Deagle, Heath McDonald, Brad Trivers, and Hannibal will be here shortly. And joining us is Ola Hammerland. Can I get an adoption of the agenda? Somebody, Corey Deagle. And today we're excited to have a briefing on home care and the impact of COVID-19. So we have Dr. Martha Carmichael here today, Mary Sullivan, and Mary Jane Callaghan. So what I'll do is I'll just pass it over to you for your presentation, and then we'll take some questions at the end. So welcome to the Standing Committee.
Great. Thank you so much. Thanks for the opportunity to present today. I'm Mary Sullivan, and to my right, Dr. Martha Carmichael, and behind us is Mary Jane Callaghan. So Mary Jane is the manager of Kings County Home Care. At the present time, the project lead for the Home Care Services Transformation Project. Dr. Carmichael is a medical director for the Provincial Geriatric Program, and I am director for Home Care, Palliative, and Geriatric Programs with Health PEI. We wanted to take the opportunity today to share with you an overview of the home care and geriatric programs. We thought that that overview would provide the context to provide your requested information on best practices in home care and some of the challenges during COVID. And we'll also overview some of our focus for moving forward. So Provincial Home Care Program does provide services province-wide, and last year served about 4,400 individuals. Those are islanders of all ages who meet the eligibility criteria for the home care program. The home care program operates with an open referral process. So that means that a client, a potential client, a concerned family member, a neighbor, perhaps a Meals on Wheels volunteer, could actually call the home care office and explore possibilities. The majority of our referrals for service are received from health professionals, but we do believe the open referral process provides opportunity for potential clients and for the community to be involved in access to that service. Individuals to be eligible for home care services do require a Health PEI card or to be in the process for applying for one, have needs that are best met by the home care program, and agree to participate in the plan of care. Our program is not considered to be a replacement for what individuals or their family and support system can best do for themselves. When someone approaches our service, we actually proceed to work through with them through a process called intake. That process determines eligibility for service, and then an individual from our team is assigned to proceed with an assessment in home. That assessment determines need, and we work with the client and their family or their support system to ensure their needs are met. We always explore options to meet those identified needs. So we look at what the individual and their support system can best do for themselves, what services they might have access to. That could be personal insurance, it could be services such as accessibility, it could be services such as Veterans Affairs. We will look at all options to wrap a plan of care around a client and their family or their caregiver at home. We will connect them with other providers who may best be able to provide support as well. Care at home is always a priority, and we support clients and their caregivers to remain home safely for as long as that is possible, to remain in their communities. So we provide services to those who need support to continue living safely at home, to individuals who have perhaps been released from hospital or discharged from hospital and are recovering from surgery or an acute medical condition, or have ongoing health issues that require more care than they can provide or than their family can provide. When care is needed elsewhere, For example, if someone needs to connect with primary care or they need hospital care, then we work to support individuals to access that care and share the information developed from the plan of care in the home. We are very focused on client-centered approach, so we work directly with these clients in their home, in their community, with their loved ones around. We explore all available resources, and we work to keep individuals home. Budget for home care services is about $23 million, about 3% of the overall health budget. For your information, on a weekly basis, we provide about 3,000 visits a week to individuals at home and travel about 30,000 kilometers. So the people who travel those kilometers are our amazing team members. They are present in island homes. They provide care to individuals who have returned home from hospital following surgery, perhaps. They support clients and families with the provision of palliative care at home, and perhaps develop a plan of care for a caregiver to support someone to remain at home rather than proceeding to facility-based care. That team is comprised of two groups. So our largest group are home support workers, and they are about 49% of our staff. The home support workers all are educated with a resident care worker course. So that's about a year-long course. And when they are in the homes, they provide support for individuals with personal care, with the activities of daily living, and also at times provide respite in the home, which is a scheduled break for an at-home caregiver. So they provide that work based on an assessed need and with a definite plan of care. The rest of our staff are professional team members, so team members who are regulated. So they would include nurses, LPNs, so licensed practical nurses, social workers, occupational therapists, physiotherapists. We do have care coordinators who are either social workers or nurses, registered nurses, and we have a small amount of rehab assistants and dietitians. We are very fortunate to have this group of individuals at each of our home care offices, and they provide services based on assessed need. Many of our clients receive more than one service. The majority of them do. Want to overview a few specialized programs. So within the home care service provision, we have responsibility for adult day programs. So at previous to mid-March, we operated 6 adult day programs across the province. Services were provided to about 135 individuals weekly. Those services were closed, not accessible during recent months with the COVID challenge, and we'll talk a little bit more as we get into the challenges. We have started reinstating those programs. Adult protection is a legislated response. That is provided by designated adult protection workers who are social workers on our team. They work to respond to referrals related to the Adult Protection Act. So that is a mandated legislated response. That act protects vulnerable adults who are unable to protect themselves from abuse and neglect. On a yearly basis, over 300 referrals are received. The Care of the Older Adult and Community at Home program, we call that the COACH program, is a partnership with home care, with the geriatric program, and with primary care, and we'll have more about that. The Integrated Palliative Care Program, another provincial program, where individuals are provided care in the setting of their choice. For the majority of individuals, that setting is home. So today, there would be about 250 individuals in the province who are registered on the Provincial Integrated Palliative Care Program. The majority of those would be at home, receiving care from the home care team. More about that. Long-term care admission. So we have, for individuals to access long-term care, there are admissions committees. They are chaired by the home care team. Prior to admission, the assessments are provided by one of our team members. And with that is the hope and intent that all community services would be explored prior to accessing long-term care. Mobile Integrated Health is also another partnership with the Department of Health and Wellness, with Island EMS, and with Home Care. That program has been in place since July 2019. It is an innovative program where community paramedics provide non-emergent in-home interventions based on an individualized plan of care that is developed by a registered nurse from the home care team. The first of three pillars for the Mobile Integrated Health Program was introduced in July 2019 as a seniors check-in program, and that is fully operational province-wide. So we have two more pillars, two more components to put in place. One has started with a phased-in introduction for palliative care, and a working group will be in place soon to looking at providing services from acute care. So that's just a thumbnail sketch of some of the services that we provide. Best practices for home care. So we've highlighted some of the best practices, certainly not all, but we are highlighting some of our work with efficiency and innovation. So a provincial, consistent approach. We work really hard to ensure that all of our services are available province-wide and that we would be providing them in the same manner so that individuals can rest assured that they would receive the same assessment. We use the same assessment process at all of our sites, and that the plan of care developed would be individualized, though, for them, right, based on their needs. We work really hard to ensure that that approach is consistent, and we think that in doing that, we are quite efficient in the use of these very valuable resources. We want to help people stay at home, so we ensure that we use resources in the most efficient way. So at our offices, individuals are assigned a lead, they are assessed, and a care plan is developed. Every week, that team comes together at the sites to look at coordination, to look at the collaborative approach to care, so that team members are aware of new referrals and they're aware of prioritization. And we believe that with those team members present at the sites, with that communication, which we really strive to provide consistently, that we are efficient in the care that is delivered. And that information is readily shared with clients and families. It certainly does take some work. We right now have a bit of a hybrid system in that we use an electronic system, but we do use a lot of paper to ensure that information about clients is communicated. It does take time. We are not heavily technology based, and we are not mobile, I would say, with technology. And that is what Mary Jane will share with you a little later in the presentation, is the project work to look at how we change that. This is a large-scale change initiative for our team to help even enhance the efficiency and to increase our ability to ensure consistent approach to care and the wisest use of resources. New approaches to support care, just highlighted a few of those. So mobile integrated health is one, and the care of the older adult at home and community, the coach program, is another. So how do we wisely use resources? Again, all with the intent of making services available to individuals and helping them remain at home. Quality and safety. Clinical guidelines, processes, and policies are in place, and we really strive to develop clinical expertise on our team. We have strong support for education, and we believe that developing that expertise aligned with best practice will help our team members support individuals to remain at home, remain in their communities for as long as possible. In turn, that does provide support for clients and their caregivers and decrease presentations to, or unnecessary presentations to emergency departments or unnecessary admissions to hospital. So if the care can be provided at home, we want to certainly support that. We have certainly seen in the past years an increased complexity and acuity in care, and I'm sure you've heard that probably over and over from anybody who presents related to health. But truly is a privilege to be in those homes with individuals, helping them meet their needs and looking at what is most important to them. Quality improvement teams are really important to our practices. So we have two that we are very much involved with, and they are both provincial in nature and both include community members. So the quality improvement teams are based on the Accreditation Canada standards, and one is focused on home care, would include representation from our team and from the community, and one is focused on hospice, end of life, and palliative care. Again, another provincial team. That team is co-chaired by myself and Dr. Mireille Lacour, and we have provincial representation from hospice, including Hospice PEI and Southern and Eastern Kings Hospice as well. A lot of work happens there, but most importantly, looking at what are the standards of care. And not only meeting, but looking to exceed those standards of care and having that vehicle of communication, again, that is province-wide. So the last component that I want to overview is access and coordination. The client-centered approach, I've probably talked a lot about that, but just so important. These individuals, it is their home. We are privileged to provide care in their home, privileged to be in their home and supporting them to stay there, supporting their caregiver or their circle of care to meet their needs. And again, not only our services, but what services can we involve? What services can we wrap around to best support these individuals on an ongoing basis? Integration of care and support as individuals need other aspects of care is just so important. I think what community does best is understand that none of us are strong alone, but together we very much are. So with the client and their family, their circle of care, their support system, we wrap services around them, with them as the main partner. The partnerships are just so important. We do not want to duplicate service, but we want to ensure that the right people are involved. And our team does that so well. They know the communities, they know the community services, they know the geographic areas. And that is really very much a hallmark of community-based care. When individuals need to access care outside of their home, then we support those transitions in care, we would call them, and ensure that that information from that client is passed along. Partnerships are just so important, and we wanted to overview a few for you. So along the continuum of care, we are very closely connected with community-based services, so with primary care, with public health, with community mental health. We are connected to the acute care system and to the long-term care system. Certainly that does take time. We to ensure that we share the information with all of those involved. Outside of the health system, just to share a few of our strong partnerships, but this certainly isn't an inclusive list. Red Cross with the Health Equipment Loan Program. We work very closely with them, meet on a quarterly basis. The equipment is so important to support individuals to return home and to remain safely home. We are very much involved in a First Nations working group, so we meet with representatives from Abequit and Lennox related to home care. Alzheimer PEI with First Link and with their dementia education. Hospice PEI, Southern and Eastern Kings Hospice as well. Their support is invaluable to individuals who are palliative. French language services, we currently have a Health Canada project to look at developing a model for individuals who are first language French. We're hoping that model of care will be able to be used elsewhere as well. Island EMS have been a partner. I've mentioned Mobile Integrated Health, but in 2015 we also partnered with them and with the province of Nova Scotia to develop the paramedics providing palliative care at home program, which is now being emulated across the country. The Canadian Home Care Association, we are an active board member, and Canadian Hospice Palliative Care Association and Canadian Frailty Network have provided an invaluable partnership. All of that helps us be stronger in our education and our knowledge, again, to pass that on to community members and the clients we are privileged to provide service to. Care coordination and the interdisciplinary teams are just so important. The care coordinators are our lead. Each client does have a lead. And when we look at what's most important to clients, what they tell us is we need to know who we're connected with. Who is that? Who do I contact? Care coordination is really our vehicle for that and for supporting integration. So our best practices, we do focus on 3 priority populations. And since I've got the time notice, I'll just overview those populations. And I think we've talked about them. We can take questions perhaps later. So we focus on 3 main groups: palliative care, post-acute, and frail seniors. Our services are provided to individuals of all ages, and they would be our 3 priority groups, not exclusive, but really where we have seen the greatest growth and greatest need, and as we have mentioned, the complexity and acuity. So with that, I'm going to turn it over to Dr. Carmichael to share some information on geriatric medicine.
So I'm a geriatrician and I work with the provincial geriatric program. And so we kind of come in, we share a lot of patients and clients with home care. Obviously, a lot of my patients are frail seniors who require home care services. I always say I love my job because I get to spend every day trying to improve the health of older adults, the independence of older adults, and the quality of life of older adults. So like, what could be better than that? One of our main goals is to help older adults age in place because that's where they want to age. They want to be supported in their community. So again, that's where our link with home care really comes in. We provide hands-on patient care all across the province in patients' homes, in clinics, in hospitals, in long-term care, in community care, all across the province. But a huge part of our role also is education and capacity building, both with the public, but also with other healthcare professionals, policymakers, etc. So it's through that hands-on care and the capacity building through the system where we actually do have a lot of collaborations between, with home care, acute care, long-term care, all of those various settings. And last, we have that we're advocates for seniors, but that's probably one of the most important things that we do and that I do in the run of the day is we really are advocates for seniors all across the system in any way we possibly can be. And that is why I'm here today. So I don't have any formal role with home care. I have no formal affiliation with home care. I've become a de facto advocate for home care because that is the one thing that I can do to improve the lives of my patients. That's the most important thing I could do to improve the life of my patients is to allow them to have more access to home care. And I'm going to briefly overview the COACH program. So this is a well-known program both provincially and now nationally and internationally. It's a collaboration between home care, geriatrics, and primary care in this province. It's been very successful. This is supporting some of our most frail, some of our most complex patients or clients at home. And we really wrap an expert team around them, and we try to prevent health crises or manage them if they're going to occur, as well as dealing with chronic conditions and managing chronic conditions and increasing care requirements. And we try to do all of that at home to support older adults living at home and to support them to be able to maintain, to stay at home in their community where they want to be. So this program launched in 2015. There was a pilot project in Kings. And it actually, the pilot data looked really good. So for the initial patients enrolled or clients enrolled, inpatient admissions decreased by 2/3 and visits to the emergency department decreased by 1/3. And that's just by providing this expert team and providing more support in people's homes. Because of that, it was expanded. So in 2017, it expanded to Prince County, and then in 2018, we expanded to Queens County, and there were investments in that program to allow that to happen. More recently, we really, our goal is to help people age in place, so we wanted to really see if we were able to do that in some way. So we looked at long-term care data. So the average length of stay in long-term care in PEI is almost 3 years, which is fairly high if you look across the country. For the 22 COACH participants who we looked at who eventually did transition to long-term care and then died in long-term care, we looked at their length of stay. And their length of stay in long-term care was only 0.76 years, which is about 9 months. So that's a difference of almost 2 years. So that kind of shows that we are able to do what we're hoping to do. For clients, patients, and their families, that's 2 years at home and in their communities with their families and with their loved ones. And for the system, that's a huge cost avoidance, right? Of not being in long-term care for those 2 years. And the truth is that that's just 22 participants who eventually went to long-term care and died in long-term care. So this does not include all the ones who were still living at home at the time we looked at this or who died at home. So this cost avoidance is probably much higher. That is some quantitative data for you, but we have a ton of qualitative data. So those are just a couple of quotes from clients and families who were involved in the COACH program or the palliative care program, and these are just two of many. This stuff's easier to come by than numbers sometimes, and you can just read those for yourselves. I think they're in your pamphlet there.
So some of the gaps identified by COVID-19. So some of them, COVID-19 really highlighted some of our challenges that we were aware of, and then there were some new components as well. So to be able to quickly provide support hours, including evenings and weekends, our team provides the majority of care through the week, through weekdays. With smaller amounts available during the evenings and weekends. We are not a 24/7 service. So when individuals, after mid-March, were moving home very quickly, that certainly presented challenges for our team. We quickly prioritized services and worked with team members to help individuals return home, to remain home. And the increased requests for end-of-life care at home were very apparent. So for a couple of reasons, we believe, certainly with the restrictions on visiting, individuals while they were journeying in palliative care wanted their family, wanted their loved ones with them, which was certainly much easier at home. And for many people, not just in PEI, but across the country, home became a safer place to be. People felt safer at home. And then with individuals who were palliative, being able to remain at home was so important. So there was certainly an increase in individuals accessing that care and an increase in individuals who died at home. So if we look at that in the past 5 years, we would have an average of between 85 individuals who would choose to die at home. Most people prefer their care at home, and many wish to die at home. We probably provide about 22% support for individuals to die at home. To this year to date, we already have supported 65 individuals with that. That does require additional resources. So with medication and with the actual hours of care. Individuals who do not have a primary practitioner, a primary physician, a primary nurse practitioner, providing that care was challenging during COVID, for sure. Not a new challenge, but definitely accentuated. Highlighting the need for supplies, equipment, and medications. So for individuals who are part of our program, the majority of them would need to provide the supplies, equipment, and medications required for care. There are a couple of exceptions. There is a palliative drug program for those who are nearer end of life, who meet eligibility criteria, and for individuals who are post-acute, there are supplies provided for 2 weeks. Otherwise, individuals must have that have access to the supplies, equipment, and medication required at home. And this certainly became a challenge during COVID, just in terms of access. Client, caregiver, family, staff fears. There was a lot of fear. Fear of individuals having us present in their home, the same care team who had visited them on a regular basis. During COVID, individuals were concerned about having our team members in their home, especially because they have been into many other homes that day. Or throughout that week. That definitely was a concern. There was a fear from clients, a fear from family members, and fear from our own team members, wanting to ensure that they were doing everything safely, wanting to ensure that that their practices were sound, and not taking anything home to their family, or moving from or taking something from one home to another as they provided care. And there certainly was fear from individuals in wanting to proceed to hospital. Another common challenge. And then the decreased access that people at home had to their own circle of support, the decreased access to volunteers. That certainly had an impact on individuals. Support for caregivers, we know how very important that is. The individuals who are at home supporting their loved ones who are palliative and dying at home. The individuals who are supporting their loved ones who could perhaps be in long-term care but choose to be at home, for them there was a distinct change in the number of individuals who could be in the home, whether it was their next door neighbor or a volunteer, or whether it was access to our day program. Certainly had a profound impact. As I had mentioned, we had provided services to about 135 clients prior to the closure of the day programs. Of those individuals, 22 of them are now in long-term care, and 6 are awaiting admission to long-term care. So significant loss of that service and incredible impacts. So we have reinstated the day program in Breckin House, a partnership with home care and long-term care, and actively working to reinstate the remaining programs. There was a decreased access to institutional respite. That respite is provided by long-term care. So when long-term care was not open to the public, our clients who at times would go into long-term care for a short respite for the caregiver, that service was no longer available. So a definite impact for clients and their families. Moving forward, we do want to optimize the role of home care as part of the care continuum, responding to the challenge and complexity and acuity of client needs and of caregiver needs. So very important. We want to support individuals to remain home or return home with our teams, our interdisciplinary and collaborative community-based teams, continue to foster and build some of the partnerships that we talked about. And I'm going to move to the last one and then go back, but to continue home care service, the implementation of investments, the supplies for home care nursing clients. We will be starting, that initiative will start on November 16th. Evening nursing hours have been added to O'Leary, Montague, and Surrey, and we are in progress to have those in place. There are additional home support worker positions provincially. 3 have been added to Queens County, 2 to Prince County, and 1 to Kings County, and they are also in progress. I'm going to finish up our moving forward with some information provided by Mary Jane. So I had alluded to the large-scale change project. We call it the Home Care Service Delivery Transformation Initiative. So that's certainly a mouthful, but really important. A big initiative, a large investment, and we are so fortunate to have Mary Jane leading that for us. So I'm going to turn that over to her.
The Health Accord funding is where this initiative started. Whenever that money came to the province, the PI government made the decision they wanted to move forward with the implementation of a new assessment tool for us to use in home care, called the InterRI is the name of it. And so a portion of the home care funding was dedicated to doing this work. The benefit of this assessment, and the reason it was chosen, is that it's a strong, robust assessment that's been created by experts and is maintained by experts, and is checked in terms of validity as we move along. So a really good, robust assessment that gives us good information. It's used throughout the world, but particularly throughout Canada, in all of the other jurisdictions, or virtually all the other jurisdictions across Canada. It is the home care assessment. We would have been one of the last to move to that in Canada, but we're well underway now. The thing about the assessment is it is a series of questions, the same as any other kind of survey or assessment. But it's very robust in terms of what it allows you to learn about the person. When you finish the assessment, you know them well. It focuses on probably 4 different areas, basically around your function. So your basic functions, so things like can you get up and move around, or eat and wash yourself, are all basic functions. It would certainly cover that. But it also covers some of the kind of higher level functions, like things like using the telephone, or doing your banking, or getting your food to your house. Those would be higher level functions. So it asks questions that allows you to learn both of those kind of aspects about a client. So that's a big part of what you do when you do the assessment. But the other piece is that it also looks at what your environment is. So where do you live? What does that do in terms of supporting you or not supporting you to live there? And then the final piece it pulls in is your support structure. So who do you have in your world that helps you to maintain your function and ability? So as you can imagine, when you ask all those questions and get all those kind of components together, you have a very good idea of who they are and what their needs are. As we move to this assessment, it has to be run on an electronic system. It's not an option. We did look to see if it could be run on the chart that we use here in the province, and it couldn't be. So we had to move to a new case management, or new electronic chart, I guess is the right way to say it, for us to use here in the province. So the assessment actually gets put into that new chart. And in that chart, then you create the care plan. So the care plan that's specific to that individual, about what their needs are and what we're going to do to try and address those needs. And then that care plan can be shared through the electronic system, obviously, to everyone within home care, and then beyond home care if we want to or need to at some point. The third component that we asked for as we brought forward this system was a scheduling package. As Mary mentioned to you, we do a lot of scheduling of clients throughout the year. So we asked if we could have a scheduling package that was part of the system, so that we could make our scheduling more efficient, but it also embeds that schedule into the chart. So that gives us really good information and allows everyone to see the chart or see the schedule as they're moving along. And then the fourth component about all of those 3 pieces is we wanted it to be mobile, so that it can be, so when the staff person's in a client's home, they would actually have the chart with them on electronic tablet or a small laptop or on a smartphone. So they would have the information they need when they're there. So those are the pieces that we're moving forward to bring into place. In terms of what we hope to achieve with those 3 pieces, We expect we will reduce the administrative burden. Currently, our staff have a combination of a chart that lives on a computer in the office and a paper chart that they take into the client's home. So you can imagine the work it is to keep up both of those systems, to keep them connected, and to share the information with everybody from both of those systems. So that will get streamlined, and that will make a big difference to our staff. They'll have the right information when they're in the home, and they'll be able to give that information to the client. That's the other really significant part about having a chart in the home, is the client can then ask questions about what's going on, and they can share that. We know that it will improve the quality of care for our clients, because we know we have confidence in this new assessment that it will give us the right information about what's going on with the client and what their needs are. We also believe it will help with system planning. As you can imagine, once you bring together a system that has all the needs of our frail seniors, what we're doing about it, and our schedule, what we're using, how many hours of service we're using to do that, we'll get really good information out of that, both for the staff person who's standing in the home to know about what's going on with the client, but also then for the supervisor that's in the office that's scheduling these folks, or for the system that needs to make some plans around who's out there and what their needs are and what we're able to do about it. We are about, and then all of that information will get sent to the national body, CIHI, Canadian Institute of Health Information, where we'll get some benchmarking. We'll get some comparison of how we're doing compared to the other provinces in Canada. So that's also really good for planning. We are about halfway through the project. We put out an RFP. We're in the evaluation stages of that. We expect we'll get into some contract negotiation and have a contract in place by January. Start implementation after January with a go-live for next December-ish. We have to talk to the company first, but that's our goal, is by Christmas next year, we'll have a new system up and running. So.
Great. Well, thank you very much for all your information on that. And what we'll do is we'll open it up for questions from the committee members, and we'll start with Heath McDonald.
Thank you. That was, I'll tell you, you don't hear many people complaining about the service that you guys provide, so it's pretty phenomenal to be able to sit here, and with aging parents as well too, because you're always kind of looking ahead. So I think you do a tremendous job. Just curious, we always have an issue with staffing RNs and so on, nurses, and I'm just wondering, has that affected your home care?
At the present time, we do have some vacancies. Most of them are temporary. Temporary vacancies are really very challenging to fill in our system. Usually, when we post a permanent position, we do have applicants. The temporary positions are very challenging, though.
Heath McDonald?
Also on, so your budget, I think, was one of your first slides, and it said it was $23 million. And I mean, obviously, I came out of government, and I know what government goes through in healthcare. It's not an easy file, that's for sure. But what additional resources? One of the biggest issues, obviously, is, or it is an issue to keep people in their homes longer and keep them out of nursing homes, and I think this program does an exponential good for that. But I'm just wondering, what more could those resources provide? That if you're doing 3,000, I think it was 3,000 visits a week, and I mean, the money that it could be saved by keeping people in their home longer, I know there's all kinds of studies out there on that. Like, what do you know what that ballpark figure would be in reference to increasing your budget? Like the budget for health is $720 million approximately, 23 million to be less than 3% or around 3%. I'm just wondering, how many more visits could you do if you got it down to 3,000 a week? Or how many more patients could you look after?
I'll start. I can start, and I know my colleagues will jump in for sure. I think what would be most helpful is to increase the amount of hours of care we provide to individuals. Right now, we do not provide large amount of hours of care to any one individual. We certainly prioritize on a daily basis who have the greatest needs and how, again, do we wrap services around these clients and their caregivers. But we know that for many of them, if they had access to additional hours of care, they would be able to stay home longer. So if we use the example that you had shared in terms of helping someone stay home rather than long-term care, I think if we added additional hours of care, and when we look at that, we would wrap that could happen in many different ways. So, for example, when we look at the coach program, we would add more spaces to that program. That would be one component. We could look at different service delivery, like a Home First program, which would provide support for individuals to return home to await long-term care admission rather than remain in a hospital. That would be another option. Some programs to support frail seniors, such as we would call it a restore and re-enablement program. Some people might call it rehabilitation or restorative care, but that would be an increase in support from our occupational therapists and physiotherapists to help them in terms of maintaining health. So there are, I would say, many different ways to look at how we would put those services in place, but just looking at that frail senior population, those would be some suggestions or some of our thoughts in terms of how we would move forward. And I might ask my colleagues to join in.
Yeah, so I guess I would say that if you look across the country, we have been traditionally underfunded. Home care has been traditionally underfunded in PEI. And even if you look at the Atlantic provinces, we are, again, underfunded comparably. And I think that this is my opinion as a physician and from working here for several years, I think what we need is just to increase the base level of funding in home care. We have fancy programs, and fancy programs are great because they have great data and they have great names. But even those programs, the bang for your buck on those programs is going to be much better if you do have just a more robust level of care, just basic care. And our patients here really get few hours of care a week, even our most complex, most frail patients. There are like a dozen people in this province who get more than 16 hours of care a week. So we're not talking huge numbers of hours. And these are people who otherwise would be in long-term care. So I agree with Mary. I think it's about increasing the hours of support for the clients in the community. And the way we do that is just by redirecting funds or starting to invest a little more heavily in home care.
I just did what you guys said.
Heath?
So, and I may have missed this when you were talking, but you talked a little bit about a shortage of supplies. Were you referencing just during COVID, or were you referencing continuous shortage of supplies year-round?
Both. It would be both. Sometimes the provision of supplies is certainly a challenge for individuals. Some supplies can be quite costly. So there are some programs that individuals may have access to, and we would help connect them with that. But we're really very thankful to be moving ahead with a new program with providing nursing supplies to individuals, and that will start the middle of this month. So individuals who are receiving home care nursing, we will be providing those supplies. So they would be things like wound care, for example, which can be really quite costly. And which individuals could access, right? If you were in hospital, that would be provided, right? If you're in emerge, that is provided. But when you were at home, you need to provide that yourself. Again, we would explore any options, but that certainly has been a barrier to care. So we're really excited to move forward with that.
Heath?
One more. During COVID, we heard time and time again from on mental health. And of course, seniors living alone, maybe not with family within close proximity, or maybe family that essential workers and don't want to visit them at home, just no different than the nursing home. Have you seen an increase in that, and has anybody tracked those situations?
I will say that during COVID, certainly we looked at how do we best support the seniors who are on our caseload. And we looked at phone calls in addition to the in-home visits. As I mentioned, some of the seniors were a little reluctant, not just the seniors, any of our clients were concerned about having individuals in their home. But we looked to certainly stay connected to them for some of those reasons. COVID certainly resulted in individuals it being more isolated, right? Which was a concern pre-COVID for some of our clients. So we looked at how can we support them, and the phone calls was certainly one way. We do know from clients that did work for them, that they were appreciative of that, and that the visit by phone was certainly helpful. For some, a visit by phone rather than in person, and for some we were able to do both. Certainly we did see, as mentioned, that the change in the access to the day program and not being able to offer that certainly did make a big difference for those individuals and their caregivers. So there are definitely challenges, for sure.
Great. Trish?
Thank you, Chair, and thank you so much for this presentation. First, let me just say that it's wonderful to hear about the change that supplies will be provided for clients who are receiving nursing care in their homes. This was something that I had brought forward in the legislature. It was expressed to me from both clients, patients, as well as nursing staff, that this was a challenge not only because of cost, which is of course important, but also that sometimes the nurses were showing up in the home and they didn't have the supplies, or they didn't have the right supplies, so they couldn't provide the care that they were there to provide in the best manner. So this is great news, and I'm very glad to hear that. I also want to say that the success of the coach program is really encouraging and exciting, and I know that it is it's fairly limited capacity at this point, and really focused on the most frail seniors. That being said, it seems like there's great potential to expand perhaps that particular program. When you look at the impact on length of stay in long-term care, the cost benefit it's not a small leap to see the cost benefit of this program. So if you were to receive funding specifically to expand the coach program, or if that was the next step, what areas would you need in terms of staffing or supports? How would you go about that to expand?
Again, I'll start, and then we can move to our colleagues. To add another group of spaces, we believe that we would look at home support workers. So they provide that very critical time and attention for the client and the caregiver, right? Both direct care for the caregiver, for the client, and some respite for the caregiver. An element of occupational therapy, physiotherapy, or a physio-occupational therapy assistant to support with that mobility and function component, and some hours for care coordination in terms of that plan of care, the collaboration and integration of care. We would work with the existing nurse practitioners and geriatricians for that first investment. That is our thinking in terms of the first additional spaces. But I'll turn it over to my colleagues?
Yeah, I would agree. So it's home support mostly, and we've been fortunate. Our program has not. We've had investments in terms of geriatric nurse practitioners, so we are not limited in terms of our capacity even to take on more clients now, except for home care funding. So we're limited by the amount of capacity we have in home care.
Trish?
Great. So that's exciting in terms of potential to move that forward. I believe it was mentioned that hiring full-time positions for nurses is not too challenging, that you've been able to do that. That is something you can do fairly well. But I don't know that we spoke about home support workers. So is it a challenge to hire more home support workers? You said they all have the RCW qualification, right? So is that, to expand that, would you have a challenge, do you think, hiring those workers? If you could do it, right away, we were going to start that.
I wouldn't say that there would be no challenges, for sure. I might just go back just to say we know there's a challenge in the system or province-wide. So not to minimize that, but just looking at how the home care team could support individuals to remain at home, and then decrease the need for facility-based care, right? Or support the facility-based care arrivals when it was required. Access to home support, we would post those positions. There is my understanding is, I think it would be, as I had shared, we would, I believe, have applicants. The system is challenged, though, at the present time with that type of worker, with access to large numbers.
Trish?
Okay, so I guess all the more reason to move forward with this sooner rather than later, because it might take a little while to get those positions filled, but the impact would be significant, it sounds like, in terms of the benefit to clients as well as to the system overall. Wonderful. Another question, you mentioned the adult day program that had to close down. Is it just one program at one location?
The adult day programs are all, with one exception, are housed in long-term care facilities. And when the long-term care facilities closed to the public, then we did close the day programs. So we have one reopened, again, with in partnership with long-term care. So that's at Prince Edward Home, the Brecken House program. And we are currently working with the teams in Montague and in Summerside.
Trish?
And so you mentioned you're working with Montague and Summerside. Are there other locations that did exist prior to COVID? Yes. Yeah.
Yep, there would be another in Kings and another in Prince. So our plan is that we would reinstitute one in Kings, one in Prince now, and are currently working on that, and then would proceed to open the other two. That, and again, with long-term care, and I need to add infection control as well, right? Because certainly the parameters, space is very different than pre-mid-March.
Trish?
Thank you. And just one more question then. So about the new mobile integrated health initiative, working with Island EMS, did that have, this is a question I've gotten before, so I'm just going to ask it, did that have any impact on your staffing numbers in home care, or did you maintain the same level of staff and then this was completely an additional service?
Completely an additional service.
That's all for now. Thank you, Chair.
Perfect. Hannah?
Thank you, Chair. A couple of random questions, filling in gaps. And forgive me if I missed this, but you just mentioned about that you're limited, some of the programs you've got are limited in capacity by the overall funding envelope. Do you have more requests for service than you're actually able to provide?
Yes, yep, for sure. We would. There are individuals who are at home that ideally we would be providing more hours of service. We look to ensure, again, it's always looking at what are the available hours of care, and then how can we safely provide them the services to help them stay home. So the safety piece is always most important, but would additional hours of care help? There's no question. It would in some cases allow individuals to remain home longer. No question. Right.
Thank you. I kind of thought that might be the case. I recognize, as with many services where we just don't have enough capacity for whatever reason, it means you have to make really difficult choices, knowing what the consequences of those choices are for the long-term care of the people that you're trying to provide the service for. Are there any conditions for client, like in terms of being able to access the services? I mean, for example, there are some services that are funded and provided where there's a conditionality around levels of income or access to other services as a priority. You know, are there any of those kind of conditions that come into play with the provision of service through your team?
We're not, we don't assess income or proceed with a financial assessment. But what we do after the assessment to look at, so what are the needs? When we get to that point and we explore, well, how can we meet the needs? We do look at what other access to programs and services an individual might have. So would they qualify for accessibility support? Would that be a program that could support them? And if so, then we would certainly make those connections. With Veterans Affairs, do they have insurance, private insurance, which could provide some of that care, or perhaps purchase some of the supplies, or those questions? We do always ask those. So those can. Those are part of our process to look at, again, how do we best use these very valuable resources system-wide.
Anna?
Yeah, and I can appreciate it. Again, it's something that we hear about a lot, especially when you're providing a service that fills such a critical space, that often that also involves navigating in and around what other things can you stitch together, right? Because one of the things I was thinking of in here, as you mentioned, things like accessibility, but also, you know, there are occasionally these programs that we find out about as MLAs. We're like, I've been here 2 years, I never heard of that. So, you know, there's funding for adaptations in the home, things like grab bars and so on, and that one does have an income conditionality on it, right? So not everybody may be able to get it, but it is a really useful program.
I just want to tag on to that. Certainly our team members are so good at that. Like, that is one of their great strengths at looking at what are the other resources, and they are just so creative at exploring that. Again, with the intent of putting as many services as we can in a home, or putting them where they need to be.
Anna?
I'm sure you are. It's one of those things where when you know that you're working on for the best possible interests, every time you learn a new piece of information, you want to tell as many people as possible so that everybody else gets to benefit from it. So like a couple of other challenging pieces around this, and one of them is actually about the great program that's happening with your electronic records system, which is so exciting, you know, because I absolutely, as a data geek, I totally get how important it is, that real time where we're at. How is that going to work with some of the other electronic record system programs and things? Because there's lots of other things going on as well. I'm thinking of the pharmacy system, digital records at the hospital. Is there kind of an overall coordination to make sure that we're not creating siloed products?
At this stage, we put out the RFP, so that is part of the RFP that went out, was to explore what their capacity was to do integrations. That's certainly a critical piece that we'll want with the new system. They'll need to integrate with our client registry. There's then Cerner, CIS will need to have some integration there for sure. And then there's other potential integrations that we'd like to explore. The new EMR record that's coming. So there'll be others that we move along. So that's part of what we're assessing, is their openness or capacity to make those kind of integrations across the system. So.
Sure. Yeah, and for that to be something that can happen as seamlessly and as sort of with minimal human intervention, right? Because every time we create those layers, there's that delay and also the potential for error. And one of the reasons for asking that is I've had a couple of cases recently that have come through my desk of, I think perhaps partly a COVID type impact where we don't have direct GP care in the same way, and when clients are maybe not as clear as to what medications they're taking, we can run into some real issues if there's not consistency in the record keeping of medication history, and that's one of those ones which is a preventable challenge to have, right? So that's really good news, and I get, especially if you're doing that in the RFP process, you can specify it there. Yeah. Not
Rose-colored glasses on, so all the dreams are still in place for me.
Yeah, we're not going to burst that bubble, don't worry. But no, I get that. I guess my last question, I think, Chair, is again another layer of complexity with our changing demographics. Here we also have a changing demographic around country of origin and language of origin. And one of the challenges we run across, in the provision, the equitable provision of services, is being able to provide services that are culturally appropriate and in perhaps an alternative language. How has that manifested for you and your team? Not an easy one, I know.
Sure. We would, in terms of language, certainly, I mentioned just specific to French language services. We do have a project. We're actually interviewing for a project manager tomorrow to develop a model of care for first language French individuals. We actually are hoping that can be a model for all language, for all the minority languages. That we're hoping that will in fact proceed. In terms of supporting individuals where there are some challenges with, if we just look at language, we do have access to some support within Health PEI for that, but that would be for an individual client, right? A translation service for individual clients. And our colleagues in public health have certainly expressed that challenge, and primary care too. So we will be looking at that, I believe, as a system, but not. I'm not aware of any specific initiative at the present time. We would, at the present time for us, we would be looking at from individuals.
Yeah, and I appreciate. I mean, it's complex enough doing this, but it's all, like I said, also part of our reality that we are no longer. It's no longer an anomaly to have, somebody who doesn't have English as a first language or French as a first language. We also have an Indigenous population, and you mentioned earlier about specific supports, and that cultural awareness becomes particularly important when we're talking about the relationships that we have with people when they are aging and dying. And I know, from my own experience of living and working in other cultures, that it can be very different. And so that piece, even if it's internal training and internal knowledge of how to navigate, is something that we're hearing more and more that we need to kind of have on our minds. Not that we need the additional work, but we have to. It's not something that we can choose not to do, right?
So true. It actually was one of the challenges at the palliative quality team this morning, really, in terms of the standards of care. How do we provide that? And while there's some really good examples, no question, how do we consistently ensure that is available so that we're not starting over all of the time, right, as a system?
Yeah, it's really encouraging now, and again, not surprising to hear that the continuing of leveling up in terms of what you're providing in service would be the great base to encompass that additional piece of the story if that needed to be. But I think I'm good there for now, Chair. Thank you very much.
Thank you. Thanks, Anne. Paula?
Thank you, Chair. You mentioned earlier that your budget, $23 million, results in a savings in the hospital and nursing care. Do you have any numbers that ties the two, like for every $1 million you spend, how much avoided hospital and nursing care is taking place?
I think the best, our most concrete numbers right now would be the numbers that Dr. Carmichael shared related to the coach clients in terms of the length of stay at home prior to going to long-term care, so that their length of stay in long-term care was shorter than the average individual who did not receive coach. Those are probably our strongest numbers.
There's pretty good data for the palliative care programs as well in terms of supporting people at home and keeping them out of hospital, but it does sort of depend on the program in terms of how much investment is required to run the program and then how much cost avoidance you see. But I mean, if you look all across the country and now the world, we are all realizing that care at home is not only better for patients and clients and what they want, but also very cost effective. But we do have different numbers for different programs, which we'd be happy to provide, but we don't really have a one number, like for this amount of investment, you get this much out of it. But generally, it's all very cost effective to varying degrees.
Can I just add one thought? One of the things that Mary mentioned or I don't think got a chance to point out is when we look at our home care clientele, we do assessments of them. The current assessment is the SAST, our Senior Assessment Screening Tool. And when we do that, over 300 of them would be leveled at a level 4 or 5, which actually makes them eligible for long-term care. So if they chose to, they could say, I want to go to long-term care, but they don't. They're choosing to stay home. So if you think about it, that's the largest nursing home we have in the province. And that's the home care program that's running that. And it's not because we're putting a ton of resources into those homes. As Mary mentioned, there's like many people don't even get 16 hours. So it's small amounts of resources. It's the families that are doing the human effort to keep them home that makes the big difference. But that's the magic of home care is a small amount of our service adds to a huge amount of service from the family and makes the big picture come together nicely. So I guess that's the other number that we have. My new system's going to fix all of those number issues.
Oh?
Thank you. Well, it sounds like a win-win situation. Happier people and less money spent. You mentioned, if I believe I heard you correctly, that you're not offering 24/7 service. So I was curious, what happens in cases where those kind of services are needed?
It's a really good question. When individuals do require that care, we'll put a plan, we work with them to develop a plan of care. And then what are they going to do if they run into challenges when we're not available? One of the innovative programs that innovative partnerships, I'll say, that has really supported that for the palliative population has been paramedics providing palliative care at home. So these trained paramedics would provide a visit to an individual who's on the palliative care program when the home care team are not available, and they would provide services based on the plan of care that had been developed by the palliative team member. So that's one component that we have. Has been really effective in supporting that 24/7 care when the home care team is not available. So generally, there's between 32-35%. We refer to it as a treat and be able to stay home, so they can go in and keep them home. So 30-35% of those individuals remain home, and the others would be transported to hospital, whereas previous they would all have been transported to hospitals. So that's one aspect. And the others we would really be looking at, if you do have a challenge, how will you work through that? So that is, that may be That may be a visit to Emerge, that may be a call to a primary practitioner, it may be a call to part of their circle of care. That's what's available at the present time. Did I miss anything? No? Okay.
Well done.
Thank you, Chair.
Thank you.
That's
Great.
yeah.
Yeah, Hannah?
I remember what it was I wanted to ask before. So you just mentioned about that the family are kind of a key piece of the circle of care. Is there a formal respite program? I know you'd mentioned respite in there, but is that something that is actually funded and supported as something that's required to help kind of balance out that workload?
We do provide respite in home. That would be with our home support workers. It's usually for like an afternoon, 3 or 4 hours at a time in an afternoon, so that the caregiver can have that time to do whatever will work best for that caregiver. The other component of rest would be short-term access to a bed in long-term care. So our care coordinators would arrange for that with the long-term care team, and the caregiver could have a break for a defined period of time, usually up to a month per year. Most of them tend to take a week at a time, usually for a couple of times through the year. It varies, but we work with them to actually use those hours because they are so valuable, right? It is really demanding work to be that at-home caregiver, for sure.
Yeah.
Hannah?
And again, it's family experience with that. I'm feeling well aware of how hard it is if you don't have that opportunity. So that's included as part of this service. That's fantastic. Because, yeah, it is. It is a matter. That's a mental health, really important part of the mental health of the caregivers.
So many aspects is so important, for sure.
Thank you for that.
Brad?
Thanks, Chair, and thanks for your presentation. It's great to see the strides that are being made to offer home care to more and, reduce the number of those service requests that aren't being filled. You mentioned that one of your key issues is you need more home support workers. That's how you would grow the program. I would imagine that funding is one of the big things, but also you'd run into challenges, and maybe you mentioned this about actually the availability of people with the qualifications. So you said it was equivalent to an RCW, basically, and that's a 1-year course, and so they have to have that, and people have to be wanting to go into it. Along the lines of what Hannah was asking about, well, may I ask this first? So I wonder, is there room in there for a qualification that's kind of like a tier 1, like a home support worker light, that can go in and provide help? I mean, you mentioned that lots of times families are doing this work, but I'm assuming that most families don't have an RCW certificate, right? But they're able to step in and do a lot of that role, not to the extent a home support worker would. So I'm looking at, innovative ways to get more home support workers, and, I can't help but think that there's people out there, especially seniors in good health, that might want to supplement their income with a little bit of income and help their neighbors and maybe even volunteer some hours. I'm sure this is all things you've thought about, so I'm wondering what your opinions are on that.
Really good perspective and point. Certainly, we have thought about that, looking at what are the possibilities. We have not made any inroads to proceed. I am aware of some jurisdictions who have done so, and I think everybody's doing just what you described, right? Trying to look at, as we move into the future and look at providing the best services we can. How do we do that? I totally take your point, and we have not fully explored that.
Brad?
So on the other side of that as well, I would imagine that there are families who don't decide not to take on that responsibility of looking after their loved one, whether it be in the home of that person or bringing them into a suite in their own home, right? Because of the work involved and the number of hours, and they may not have the time, especially when it comes to financially. If they're working a full-time job, I just, can't make it work. I'd have to go to a part-time job or no job at all. So again, I'm wondering if there's opportunities there somehow where you could offer financial supports to family caregivers so that they would choose then to become, I guess it's that home support worker light again type thing, choose to step into that role instead of the person going again into long-term care or elsewhere. And I know this has been talked about before, and I just wondered if there's any progress being made.
Definitely, we continue discussions on what that might look like. We haven't had any, I think it would be fair to say we have not formally progressed with that, but definitely consider that an option. And want to continue, an option to continue exploring. Because certainly we receive those same calls, right? And have those same discussions with family members, for sure. Many of them who say exactly what you articulated, right? So as a system, how can we best support that?
Brad?
I just want to thank you again, and hopefully those are the sort of things that you'll be able to continue to pursue. And maybe that's my last question is, in particular, those last couple of areas, what sort of supports would you need from government to be able to, more formally pursue those? To try and get these home support worker light type people in there so you can expand and service more client requests. And
I think the starting point would be to look at the work that's been done to date and bring it up to speed right now, and look at how that might apply across the province, what a potential plan of action would be, what the costing would be, who we would need as partners. So I think we would start with a development of that, a formal development of that concept. To start. That's what I would say. And I guess, and maybe not to start, but to add to the work that's been done to date. And I think then, you could look at what's been effective in the other jurisdictions. It's not always easy to, in fact, usually we have to do some massaging, right? Usually can't take a template from another jurisdiction and just apply, but what have they found successful, and how would that best work here? And always working with the other partners in the system.
I'll jump in, Mary. We have, as a province, embarked upon the development of a seniors health services plan. And so a lot of these issues are much more broad issues, right? Big policy decisions, which kind of a lot of it is kind of within the purvey of home care and health PEI, but a lot of it is external. So the goal of the Seniors Health Services Plan is to really have a broad overview and think outside the box and try and see how can we make these things happen. So things like the Seniors Independence Initiative have already started down that path, but maybe we need to look at that program again to see if we can make it a bit more user or client friendly. Self-managed care, providing money to families to spend how they want in terms of providing care. Tax credits, like all of those things are for sure important and are going to absolutely help us care for more people at home. But a lot of it is kind of external to your operational.
For sure. Really, really good point. It does, and I think that's why we need to look at, like, who would you partner with, and to your point, some of these are broader policy decisions, like how as a province do we wish to proceed to provide support for these various populations. And I think together, like, we can certainly make some really strong changes.
Okay.
And I'm glad you brought up the Seniors Independence Initiative, because I think that was a really good one. Of course, it is means tested as well, which, you know, maybe is a good thing, you know, because there's lots of third-party services that will provide that as well, and we want to give them a chance to make a living as well. But it seems to me, and maybe that's what you're saying, is this is, you know, cross-departmental and requires that higher level sort of initiative. And I know there's different committees in government that look at those sort of things. They typically have lots and lots of, you know, things on their agendas. Like the Social Deputies Committee, for example, would be one that comes to mind that might fit in their realm, potentially, maybe not. I guess if you're thinking of anything right now of a particular group where this could go to, as opposed to just has to go to a higher level and we'll look at it, I mean, I'd love to make those sort of recommendations. Like, you know, I work with this particular group in government. If this was higher on their agenda, we could make some inroads, you know, that sort of thing.
Thank you. Just a few questions here. So COVID happened in Prince Edward Island, and that, to me, like in a general sense of the population, people were less active. They didn't move, and in the seniors population, I think those things become magnified. You know, for example, a lady in my district, she goes to the swimming pool, wasn't able to go to the swimming pool. I see that she's advanced closer to needing support than she probably should have. Are you seeing the same things right now in your field? Could you talk a little bit more about that?
I think we have all seen that, and we see it everywhere. So we see it in the community, we see it in community care facilities, people that are needing a higher level of care. We see it in hospital, and we see it in long-term care. And so now we see our hospitals full of people who are waiting for the mythical better place. And we've seen a huge physical decline in older adults, cognitive decline, and also mental health decline as well. And I think there was a question earlier about whether we're tracking this. We're not tracking it well, I don't think, in PEI. It's tough for us here. It is sort of being tracked a bit in other parts of the country, and it's certainly something that we've seen all across the country.
So it's kind of worrisome because that's why we're having you in to talk about this, because 2 weeks ago we had the Deputy Minister of Social Development, and he was talking, I think, about the population forecast for Prince Edward Island. The seniors population will go up 30 some odd %, mixed with the issues that we're talking about. We're looking at a crisis situation in Prince Edward Island. Are we? I guess we have to do things right now that will change that, and maybe COVID is the right time to kind of reset that. I would think. A couple of questions around. So thank you for your work you've done with dementia and Alzheimer's. Prince Edward Island, it's just fantastic. It's amazing, and we did get some unbelievable numbers about dementia too, and the way it's going. I think you just addressed that. And with the situation that happened with Unit 9 and dementia patients coming in, is what happens to home care around dementia? I guess it might be but how do you know when to transition? Obviously, if we're transitioning to a makeshift Unit 9 area, that's not a sustainable model for Prince Edward Island. Could you just touch base about that and how we do better? It's a sorry question.
Yes. So I will first say that home care does a wonderful job at really getting to know the clients in the community and aiming, if at all possible, to avoid situations where clients or patients end up in situations they would prefer not to be in, like in hospital, ALC, awaiting long-term care. So the goal is to provide a smooth transition from the community to community care if required, or to long-term care if required. That doesn't always happen for a lot of reasons. I think that we're just in a tough spot. We have traditionally relied on facility-based care and bed-based care, and we're not alone. Like most of the world was like that. I think the world has realized in the last 20 years, Denmark realized it about 25 years ago, 30 years ago, that we do need to shift care to the community because that's what patients and clients want. And so yeah, we are, it seems like a crisis now. I certainly haven't quite seen it this bad since I got here a few years ago. But what a perfect opportunity to make the changes we know we have to make. What a perfect opportunity. Now is the perfect time to do it. Because I don't think we do have much of an option. I mean, and with ALC patients in hospital, the question is always, where can we put these people? Where can we move these people? But that will always be the question, if that's always the question, right? So it's not about that. It's how can we get more people home? How can we keep people home? How can we support them at home? And it's really what you have to do first is shift that funding. It's not pulling it from anywhere. It's just investing in home care and community. And then over time, you have less and less requirements for acute care and long-term care.
Excellent.
And we've seen that in other jurisdictions. It's our time now.
Excellent, excellent. That's good. And I just have a couple more kind of ideas. Food security becomes an issue that we've talked about a little bit. But it's also a way that if we're able to, I would look at the Seniors Independence Program, if there was a food security component to it where somebody was getting a meal once a week, how much a difference would that make, and would people look forward? Is that something that would be an attainable kind of solution, or something that we're moving in the right direction? Or do we do enough around food security for seniors? And I'd give you an opportunity to talk about that. Yeah.
I think in terms of what comes to mind is when we are in the homes, I think one of the first things somebody said to me when I started working with home care was, you really have to have a special relationship to go into someone's home and open their fridge, right? To see what's there. And so our team members do that, and then look to support. The Meals on Wheels program, I think I would be remiss if I did not mention that. That is like a strong support for many seniors. In some communities, they have the opposite of that, and it's kind of like Meals to Wheels. So restaurants in local areas will also provide some of that as a takeout. Our teams would connect individuals to the supports, whether that would be a food bank, whatever worked for that individual, right? Depending again on what supplies, what access to funding they had, what their support system was. They've come up with very creative ways to support that. Sometimes it can be a neighbor, right? Sometimes it can be the group who live in perhaps a seniors housing building. So there are some creative ways, but again, it's the time to develop that, right? So sometimes that happens. I'm not saying that it does all the time, but we do have some examples of that. But definitely a concern for sure. Anything
The
else?
other thing I would add, I guess, is that just as a manager in connection to clients, there are times when we would hear about clients who didn't have the money to do all the parts they needed to do. Like they exist, and they're making some really hard decisions about which way they go. And those are just the few that we hear and we can do something about. We do know there's more than that, of course, that we wouldn't even be aware of. But I guess they are out there, and they have very strong, sad faces that are making some really hard decisions in terms of whether or not they buy their food or their medications or pay their rent or get a transportation, pay a taxi to get somewhere. Life can get very expensive for some of these folks. So that's all I guess I would share, is that I've seen the faces, heard the stories, and they are challenging.
Yeah, and maybe we have the Minister of Education here. Maybe it could be the school and senior food program.
Brought up before.
Well, there we go.
And dementia specific, so the two big things that we run into issues with are meals and medication supervision. And those are two things that just kind of fall through the cracks. They don't seem to be anybody's job necessarily. So yeah, I'm always railing about the sandwich. Would someone just make the sandwich? But it's tough. And again, those are things we have talked about in terms of the Seniors Health Services Plan as gaps.
Yeah. Perfect. And the last question that I'll have, and I'll just put it all into one. I know that falls prevention is a massive issue around home care and seniors. And you look at it, you look at what happened, a little snowfall this morning. I just kind of crossed my fingers. I know that people haven't been moving for a long time. They go outside and it can happen that fast, and it could change their life that fast. Are we doing enough for falls prevention education and outfitting people's homes for falls prevention help?
We have a very nice screen and a nice assessment that we use to try to identify individuals, and then would make some recommendations around things they should change, things they should do. But it's very much at that level of a recommendation. We don't have the humans that can go in and do the exercises that can build up the strength for the clients that they would need in order to make some really significant differences. So I guess we do what we can within that realm, but we do know there's lots more that could be done.
The home care occupational therapists do very good home safety assessments with folks. And I think primary care, and so that's even only the people connected with home care, right? Which is not a lot of the 32,000 seniors who are now in PEI, so we're still missing a huge chunk. Primary care, I think, does what they can. But in my dream world, there would be free exercise and falls prevention classes for people across the province. Happens in other provinces. It would be great. It's just the intervention that we could use a little more of.
Yeah, absolutely. Well, thanks for that. Is the committee okay? Excellent to come in today. If at all, you're welcome to submit. We're writing a report, which will be very, very soon. I think this is very important to get your information. If there's some things that you think about that you would like to add to the report, just send it along to the clerk. But at this time, if you wanted to add 2 or 3 things, or did we cover everything? Selma? Great.
No,
Excellent.
thank you. We really appreciated the opportunity to present. And we appreciate we only gave just a broad overview, just a thumbnail sketch. So thanks for that opportunity.
It was an excellent presentation. So thank you again for coming in. What we'll do is we'll take about a 2-minute break, and then we'll conclude our meeting. But thank you very much for coming in. Great. Thank you very much. So we're moving on to number 4, the discussion of scheduling. If the committee is agreeable, the next meeting schedule will be over the evening recess when the House is open. So, yeah. So that's as best. I think there's a lot of that happening. But we do have we've been meeting quite a bit, so we'll have a pretty extensive report, and we would try our best to limit those meetings, obviously. So,
This would be a consideration of report meeting, Chair?
yeah.
Yeah? Would you
Yeah.
be able to have the draft report in advance? Okay, great.
Yeah, so that's number 4. Anybody else want to just to put it on your radar anyway? So that was number 4. Number 5, new business. New business. I do have one thing to bring up under new business that wasn't on here. The minister, we were chatting about the Unit 9 movement there, and we were talking about having the minister and the deputy minister. They did agree to come in, but they were unable to come in on today, so they were supposed to be in this meeting. They have talked about rescheduling potentially for Monday. So, and obviously with the ledge opening up, I just wanted to kind of ask the committee members, I know Monday's a sacred day. This is a fairly important issue for Islanders. It's up to the committee to discuss this and see if we would want to entertain a Monday, special Monday meeting. Yeah, Trish?
So, if I remember correctly, this was specifically around Unit 9 and the reopening of Unit 9. So it has reopened, but only in half capacity, and there's still, I believe, 8 patients with dementia who are in a segmented area of the unit, and there's been renovations. I don't know what that means. Perhaps if we can't have the minister in to present, we could get a written explanation or description of what exactly is happening, with Unit 9. What are the timelines to open it completely back to regular capacity? And I would like to know what renovations occurred, how much they cost, and what, I guess it just seems like a big undertaking. I'm wondering how long they're planning to maintain those 2 separate populations in that space. So those are some of the things that's what I would ask if he was here. So maybe we can just get something in writing if we can't have him in. I don't know.
Okay. Okay, with the.
How others feel about that.
I agree with Trish.
Okay. Everybody's okay with that concept, and I guess we'll kind of, moving on from that, what would anybody else would like to see in that letter?
I think we need to make it really clear that there's a timeline on when we want an answer.
Yeah.
Because in lieu, if they're being let off coming into the committee, we can't wait 2 months for that answer. That is, it needs to be made a priority for a response, because the alternative is you come in.
Okay. Okay.
Also question period that week too, so I'm sure it'll be.
Oh, I'm sure. We're going to get answers though.
Education.
But,
Yeah.
Ask questions.
I think the letter's a good idea.
Yeah.
There's many ways to find answers.
All right. And maybe I would ask what is the plan around a potential second wave with that space?
That's a good point.
Yeah. Anything else we want to put in there? And just no. Okay, perfect. So that's
To that, the private long-term care folks, when they were in, said that there were proposals that went to government for space to accommodate the dementia patients who are waiting. Whatever became of those proposals?
Yeah.
I guess.
I think they were offered 16 unit, or he offered them 16 beds.
Right. So we don't have 16 patients there anymore. We have 8, but, are there other ALC patients that are waiting, if not in Unit 9, in other places with dementia who could use that space and have a more permanent and appropriate care setting?
Perfect.
I don't know.
Okay. And then, so we'll send that letter off maybe by tomorrow, and then ask for a response. What's today? What would be reasonable, committee?
Response to the letter?
Yeah.
From the committee or from the minister?
As in there, we would say we'd like, I know it's a tight timeline, but we'd like a response by
I think you at least have to give them a week.
a week.
I don't know, that's,
Okay, we'll give them till Monday, potentially, if that's okay with the committee.
I think that's a little unrealistic.
Okay. Yeah.
Yeah. They should be
Trish?
able to answer these questions pretty quickly, and I would suggest it's to the minister's benefit to provide these answers to us before the House sits, honestly. I mean, you know, if he has the answers, he should let us know them, and
Okay,
just be easier that way.
it would be okay if we could put, we would like to receive these prior to the sitting, the opening of the show. Okay, perfect, thanks a lot. All right. Any other new business this time? No, perfect. Can I get a motion to adjourn? Brad Chivers. Meeting is adjourned, thank you.